And you even get a view of, this room has a camera angle
Right
over there, so that's where the camera angle is, okay?
Yeah. All right. Okay.
Good morning, M2s. So I know we have a couple of minutes, so I just wanted to, for those of you who do get to listen to the recording, this is our only way of staying in contact. Hopefully, it's been a good start for the block 524. I'll just repeat a few things. I had posted a block overview PowerPoint under week 1. So the way the structure of the block works is I have this course materials, and then you'll see on Blackboard on the left-hand side, everything is organized by weeks. And then if you tab week 1, you'll see the course notes for it. You'll see the week 1 PowerPoints. You'll see the path of his case for the week. And then whenever we have the final version of that case, we post it there too. Week 2, exactly the same way. I just wanted to underscore what I had put in the PowerPoint. It's the same thing that's in the fact sheet, so it didn't make any sense for just having you guys come here for half an hour on a Thursday just to listen me telling you the exact same thing, but it's posted over there. There's a certain strategy and a theme for this block. So the way it works was that first week was meant to get you guys introduced to cardiac pathology and introduction to CV Pharm. The whole idea was that you get a concept of valvular heart disease and heart failure. So between your sessions in PAPHS last weekend and today and tomorrow, hopefully that will close that loop on it. This week, the theme is coronary artery disease. So very big diseases that you guys need to know about no matter what field you end up in. So heart failure, big disease. You know, we're talking about that valvular heart disease. This week, coronary artery disease, #1 killer in the United States. So we're actually, that's sort of the theme set up. So starting with today, I wanted to make sure I get this talk. Rather than let you listen to a video, I wanted to do this in live just to kind of emphasize some key points. I know you lose some inflection on the video, but I think this is important enough. So all of you who are listening or will listen to this later, do treat this. Follow the PowerPoint along with the recording. Stop it. You don't get something, repeat it. This is very, very essential. It's sort of the basics of the diagnosis of an MI. Dr. Decrease, one of our eminent pathologists, hopefully will lecture on the enzymes piece of it at 11. And then hopefully tomorrow, Dr. Betelich, whose recordings you've heard, very nice, succinct recordings, he'll be here to give an in-live lecture on pericardial diseases, which is also going along with the theme of the week. And then he'll be here a half an hour earlier, about 9:30. I asked him to come in a little bit hours. I know on some of your schedules it lists as 8 to 10, but it's just 9:30 to 10. Just feel free to ask him any question you have, anything that didn't make sense. And then and then Wednesday, I think EBM. Remember, EBM is not part of this block, but you have EBM going across the year. So if you have any questions about that, feel free to contact Drs. Lynch and Patwari. There's a summative assessment review that we always have. I think you've had those in your M1 year. You'll continue to have those, so that's on Wednesday. Dr. Richards will prepare a nice PowerPoint. We'll go through some of the questions that you guys struggled with on the 523 final, which wasn't that many. I mean, that's a fantastic mean that you guys had. So probably not a lot of questions for you guys to even worry about. Thursday, it's set up for pharmacology again. So if you think about it, the theme of this week is coronary artery disease. A lot of the drugs you're going to be learning about on Thursday have to do with, hey, how do we treat angina? How do we treat NMI? How do we treat this? So that's sort of the theme. And then Friday is a sort of a formative assessment. You're just responsible for everything through last week and just today. That's it. And then remember, we have 2 of them in this block. One, so you get to drop 1, so just 1 counts. And then we have a midterm exam, which is a summative exam, so that counts. And then there's a final exam. So the midterm exam is after just the first 3 weeks of the block, cardiac, so just all the cardiac stuff. Week 4, we'll start pulmonary. So the way we work on the respiratory side, the theme, so week 2 theme is coronary artery disease. Week 3 theme is arrhythmia. So remember the heart's the plumbing side and the electrical side. So we focused on the plumbing side for the first 2 weeks. Next week is all about the electrical side of the heart. Week 4, so right after your midterm, we'll then move into the lung. We'll focus on infections of the lung. And then in the 5th week, it'll be about diseases of the lungs, your COPDs, your obstructive diseases, your restrictive diseases. And then the last week of the block will be sort of the cancers of that area and head and neck. Head and neck is part of our block. So certain blocks this year, you'll notice that certain pieces of information will like, oh, where do they fit the best? So like eye might be part of skin later in the year. Or head and neck will be part of this. So that's just Monday and Tuesday. And then you have a bunch of study days, and then you'll have your final. Throughout the process, there's certain review dates on your calendar that I'll be here to do formal reviews of both of your PAPHS cases, mid-block reviews. So while those obviously are not mandatory, please do. People have benefited from them in the past, so just keep an eye out for those. So those are just some of the key highlights of the block. Pretty straightforward. There's plenty of time in the block for you guys to catch up. As you notice, not that many lectures compared to what you had in MOD, but these require you to go home and actually think about things and maybe hopefully understand them, and then tie them in your PAPHS groups, which is what you guys have been doing very successfully. So that's fantastic. So just quick overview about the block. The breakdown of the final grades, it's in that PowerPoint and in your fact sheet. So 5% for your formative, something about 25% or so for your mid-block, and then 70% for your final exam. So that's how the grade gets determined at the end. There'll also be a formative in the lung side, so I guess whichever one you do the best on, that one ends up getting counted the most. And I'll decide what to include in that. It's usually, we kind of say, oh, maybe the week before plus a couple of days before, something like that. I'll probably make it more like an infectious pulmonary formative, and then the other stuff will show up in the final. But just try to keep up. Hopefully you've had enough time. It's been 7 days, hopefully. I think the material isn't too much, but it's a good pace. But just do try to keep up. This is kind of stuff that if you fall back on, it's really, really hard to kind of catch up at the tail end. So just kind of stay with it, and hopefully everything will work out. And it's again, no need for me to underscore. These are highly. This is a big chunk of your material for steps, and so obviously, the cardiovascular system, respiratory system. A lot of what we ask you about and test you about incorporates the knowledge that Dr. Shannon imparted to you guys last year in his block. So a lot of what I do is sort of just based on everything he did, and then just adding now the disease states on top of that. So it's our expectation, the physio, and then you can kind of build on that. Okay. So that's just the block at a large. Everybody clear with that? And I like communicating through the Blackboard thing, so don't get annoyed by my messages, but I'll keep like on a week by week basis, Fridays or Saturdays, I'll kind of fill you in on, okay, here's the PowerPoints, here's what you got to know, and so on and so forth. All right, so introduction to electrocardiography. I may have talked to your group when you guys were M1s. I think Tom was nice enough to have me come by, and we just did a very brief introductory thing on this when he was talking about action potentials and things like that last year. But let's say you know nothing. Let's just start from scratch. And if some of this is is simplistic, great. That's how it's supposed to be. So the idea is to just get you in the ballpark. You're not going to be experts in this today, but the idea is just that, okay, I at least have an idea of what this is, and I have an idea of why we use this. This is my disclosure statement that I think I'm supposed to give before any. I don't get money from anywhere else, but I do serve on the ABIM. I'm on the test writing committee. So hopefully I'll give you on the indications of an ECG, rate and rhythm using the ECG, waves and intervals on an ECG. You can say both. You can say EKG or ECG, German versus English, kind of different. So electrocardiography or EKG, that's the same thing. Describe the waves and intervals, bradycardia, tachy, a location of a lead to the anatomy of the heart. This becomes a very big deal. And recognize AV blocks and identify and localize coronary ischemia and infarction. So hopefully some very basic things that we will get you guys to go over. All right, this is a normal 12-lead EKG. Basically, think of this as an electrocardiogram as I described it to you last year as location, location, location. It's like real estate. All you're trying to do is get information about the heart. And you're trying to get information about the heart from as many different places that you can get it. So for example, you see a car, at an auto show or in a dealership, and they're always giving you their pamphlets of the cars, and they're like, okay, that, and then you usually have, or if you're scrolling through your iPad, you're like, oh, that's the front view. Oh, that's the diagonal view. Hey, that's the top view. That's the bottom view. That's the view from the back. That's the view from the side. That's what an EKG is. Each one of these 12 leads are places on the heart, and you're getting a view from that particular location. That's all this is. So lead 1, 2, 3, all of it is these leads are placed on you. They're placed in a way so that they can get certain location information about your heart. So we're getting information. It's like a GPS. Think of it that way. So you're getting GPS about the posterior part of the heart, the anterior part of the heart, the inferior part of the heart, the lateral side of the heart, the anterior lateral side of the heart. So all of these different areas. And the more leads you have, the more information you have to make that summative judgment. Okay, where is the problem? So you're tracing electrical activity from different locations. The electrical activity is the P wave, the QRS, and T. And atrial depolarization, ventricular depolarization, and then the repolarization. And so that's essentially what you're getting is that piece of information, the electrical information of the heart from 12 different locations, and sometimes that can tell you not just about the plumbing of the electrical side of the heart, but the plumbing side of the heart, that maybe something is defective because it's creating an abnormal rhythm. All right, so there's 6 leads on 2 sides. So we call, your heart sits like this, sort of like your fist in your chest wall cavity in your thoracic cage. And if you were to take this view around, hopefully the camera can see me, this view around, that's sort of called the precordial part of the heart. So that's sort of the horizontal plane. And then there's a vertical plane. So that plane, your horizontal plane, the precordial plane, we call that the V side of the heart. Because traditionally, if your heart's sitting like this, and if you remember from anatomy, most of this part that's anterior are your ventricles. It's your right ventricle over here and your left. So that's why they came up with the term V. So your V leads sort of go V1 through 6 is pretty much a lot of information about your horizontal precordial portion of your heart. The limb leads are sort of going up to down, so sort of that vertical plane of the heart. So you're now getting information about from that plane, the whole vertical plane, and you're getting information about the horizontal plane. And so for the precordial or ventricular leads, that's another way to put it, you have the first one put on the right sternal border on the 4th intercostal space. And then the third one is put midway. So the way I like to remember this is that there's a midclavicular line, then there's an axillary line, and you put the 4th one on the midclavicular line, you put the 6th one on the axillary line, and you put the 2nd one on the 4th on the left sternal border. And then the 3rd one is the one between 4 and 2, and the 5th one is the one between 6 and 5. And then 1 is right on the right sternal border. So you get 6 pieces of information. So in your mind, if you're already thinking, you're like, wait a minute, so V1 might be the right ventricle, V2 might be that septal area, it might be right ventricle, V3, V4, V5, V6 might be the anterior, and then 5 and 6 might be the lateral side of the heart. So already in your mind, you're thinking location, location, location. You're like, okay, if there's a hypothetical issue with V6, I'm thinking about the lateral side of the heart, and then bing, 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 you're like, what supplies the lateral side of the heart? And now you go back to your coronary anatomy and you say, okay, it's main, so we got the right, it's the left main, it breaks down into the LAD and circumflex, and that's the right coronary goes inferior, LAD, maybe mostly my anterior side, the circumflex may be coming a little bit down lateral, and then you remember your right dominant based upon which supplies the posterior descending coronary artery, right? That's how, I think 20% of us may be left dominant, but that majority of us, that's how it is. So that's how you kind of figure out these locations. So that's sort of just where you put the V leads. Again, that's just a tracing of where the V leads are being put over here. So it represents the electrical activity of the heart, its rate, its rhythm, its axis, its hypertrophy, and injury. So these are some key things that we can find out from this thing, from an electrocardiogram. A basic rule of physics, I don't want to get too bent up in this, but if a deflection is upwards, if the wave is going towards a lead. So hypothetically, if I am standing here and a current is coming towards me and the paper is here, the tracing will go up. If the current is going away from me, the tracing will go down. So if you have an upward tracing in a location that you're sitting, let's say I'm in V6 and it's going up, you're like, it should be going up because sort of that's how the current flies, SA node, AV node, and it goes that way, and you're like, oh, that makes sense. However, if it was going the other way, you start thinking, wait a minute, the current is going away from this area, it should be going, so maybe there's a problem there. So that's just what this means. The positive complex implies a deflection going upwards, is the current moving towards you, positive deflection. And then, so it's normal in some leads to have a downward deflection because the current is not going in that direction, it's going away from it. And it's normal in some areas to have an upward deflection, not a downward deflection. So everybody clear? All right. So on an EKG paper, if I go all the way back to the beginning slide I showed you, you will notice that we have these boxes. All right? From here on out, I'm going to be referring to this one as the large box. And within this large box, you see these teeny-weeny itsy-bitsy boxes. And from here on out, I'm going to be referring to these as an itsy-bitsy box. So from here on out, this is sort of the vertical plane. This is the horizontal plane. So from here to here, from here to here is 0.2 seconds, because this is time, and this is sort of voltage over here. All right? So right from here to here, one large big box, the boundary of one large big box to the boundary of another large big box is 0.2 seconds. There's 5 little itsy-bitsy boxes in here, so that means each little itsy-bitsy box is 0.2 divided by 5, which is 0.04 seconds. Keep that in mind. That's the basis on which how you calculate the rate. So we'll go right back up here. And so one small box, that's the itsy-bitsy box. That's 0.04 seconds. The one large box, the one I showed you, is 0.2 seconds. And obviously, 6 large boxes is 1.2 seconds. Just math. All right. So here, what we like to do is we like to measure the number of big boxes between your PQRST, so between an R and R interval, how many big boxes is there? So if you had a QRS, every one large big box, that means every 0.2 seconds you had a QRS complex. What would your heart rate be? So that means 0.2 seconds, 1 beat. 60 seconds equals how many beats? So that's 60 divided by 0.2. That's 600 divided by 2, 300. Therefore, if you have an impulse between every large box, your heart rate is 300. If it's 2 big boxes, it's 150. If it's 3, it's 100. If it's 4, it's 75. So this is a nice way to guesstimate the rate. You look at the tracing, and you look at the QRS complex, and you go from one R to the next R, and you say, how many big boxes in between this? And so it's roughly about 3. Your heart rate is 300, divide by 3, 100. Everybody clear with that concept? So you now know how to do rate. Okay? So that's rate. If there was 5 big boxes in between the 2 complexes, 300 divide by 5, your rate is 60. If there's 6, your rate is 50, and so on and so forth. If there's only 2, your rate is 150. Now, that's rate. Where does where does the rhythm of the heart originate? Where does the rhythm of the heart come from? The rhythm of the heart comes from the SA node. All right, so it's sinus. That's why we always refer to on the physical exam when you write down regular, rate, and rhythm. Regular rate is the rate thing that we were talking about. That's what you guys measure when you're feeling somebody's pulse. That's the rate, right? You're like, oh, his pulse is 80, his pulse is 60, his pulse is 90, rate. And then sometimes you also comment on the rhythm, and it's regular rhythm. And you're like, so it's sinus. So there's a P before every QRS. There's a P before every QRS. Just think of it that way. So rhythm. Now let's talk about rhythm. So you have to decide if the rate is fast. So that has more to do with the rhythm, just like a rhythm on a string instrument, but that you try to focus in on. So there's the rate side of it, the pitch and the sound, and then there's sort of like the rhythm side of it. Decide if the rate is fast. So if we have something over 100, we term it tachycardia, or slow bradycardia, or normal 60 to about 100. Decide which pacemaker is responsible for the rhythm. So if you're between 60 and 100, it seems like your SA node, your primary pacemaker, is working well. If, however, something happens, whatever happens, disease process, and that's not working, the default is your AV node. But remember, the rate of the AV node is about 45 to 60. So that's we call it ventricular AV nodal rhythm. Unfortunately, if let's say you knock out both your SA and AV nodes, and you're just stuck with your ventricular intrinsic impulses, that's about 30, 35, 45 range. And that might be a generous estimate too. So all may be faster or slower depending on the cardiac pathology. So just some very basic concepts so you guys are on the same field as we all are. All right, normal sinus rhythm. A P before occurring regularly with identical morphologies before a QRS interval. PR interval is constant and it's within the normal limits. It's not delayed, it's not inverted, it's not none of that. So that's normal sinus rhythm. QRS following each P wave. And the PR interval is normal. Good, we're right on cue. All right, perfect. Okay, normal sinus rhythm. Okay, so this is just, again, P, QRST, the large box, the 0.4 second box. So if I was to look at the number of large boxes between these two R waves, one large box, two large boxes, 3, 4, maybe close to 5. So roughly, if I was guesstimating the rate here, I would say 300 divided by 5. This person's right around 60. I mean, you can put 62, 63, but that's kind of how we do the rate. And there's a P wave before every QRST. And the PR interval, so we'll talk a little bit about that now. So just reminder again, this is our grid box, the itsy bitsy box, 0.04 seconds. This is our large box here, okay, that's the 0.2 seconds. Very key definitions here. Sometimes you guys will get these wrong. So from the beginning of the P wave to the beginning of the QRS, that's the PR interval. That's the PR interval. This part over here, where the P wave kind of domes down, that's called a segment. That's not the interval. So this is the interval, PR interval, and this is the segment. Everybody clear with that? The QRS interval is here. So from the beginning of the QRS, and that's the QRS interval, and here's the SD segment. That's not the QRS interval, that's the SD segment. And then you did learn about this last year. You talked a little bit about QT interval and I think some genetic issues related with QT syndrome, long QT. I think there was something in your syllabi about that. And so you guys are well versed with this. Some drugs that you will be learning about do affect these all year. So it's a common step question where they want to get you guys about the QT and did they recognize this was a QT thing going on here. But anyway, so that's the QT interval there. We won't focus too much on it today. And these are the things that are very important. PR interval, segment, ST segment. This is the ST segment that everybody talks about. Not from here, but from here. End of the QRS to the beginning of the T. And we will not at all talk about the U wave today. Okay, again, same grid box here. P wave, it's the first wave of an electrocardiogram, atrial depolarization. So now, this interval, it's about 3 to, I would say between 3 to 5 itsy bitsy boxes is considered a normal PR interval. So 3 itsy bitsy boxes is about 0.12. So we go 0.04, 0.04, that's 0.08. Yeah, so up till you get to about 0.2, anything over that, it's increased PR interval. Okay, so 0.08 to 0.11 is the most common one, but anything from the 3 itsy bitsy boxes to about 5 itsy bitsy boxes is an okay PR interval. It should be isoelectric, so like going up and coming down to the same spot, and here. And this is the atrial depolarization, which is only 2 itsy bitsy boxes, like it says over here. Prolongation usually implies delayed conduction through the AV node. So obviously, atrial depolarization, it gets to the AV node and it has to be conducted, right? So if there's a delay in that PR interval, it means the QRS didn't fire off when it was supposed to. So it got delayed. Okay, so let's remember that concept right there. The QRS complex, that's what's missing here, is this is the QRS, represents ventricular depolarization, and there's an initial downward deflection before an upward deflection, and that's referred to as the Q wave. Sometimes this term comes up about Q waves and being pathological if they're a box or two deep or a box or two wide. But we'll get to that. First upward deflection is known as the R wave, and then the first downward deflection after an upward deflection is known as the S wave. Normally, it's about 2 to 3 itsy bitsy boxes, so about 0.06 to 0.12. And anything greater than 3 itsy bitsy boxes is, we call that intraventricular conduction delay. All right, and there's very few things in medicine that cause you to have a widened QRS. One of them being a bundle branch block, and the other one being sort of an ectopic rhythm. So very few things. So it's very easy to know that there's a problem here if your QRS is prolonged. Okay, so this is duration. Now remember, I talked a little bit about this axis being voltage and this axis being time. So the y-axis or the vertical axis is your voltage. Think about the size of your muscle that you have. So how much, if I have a thickened muscle, do you think the voltage would be higher or lower in a thickened muscle or a thinner muscle? So thick muscle, higher voltage or low voltage? Higher voltage. Very thin, you wouldn't have a high amount of voltage. They're just going back to the rules of physics. So therefore, if maybe you have hypertrophy, you may be having a more upward deflection. And that's sort of how we pick up hypertrophy on an electrocardiogram, primarily based on voltage. And we'll talk about that. So small, narrow Q waves may be normal in 1, AVL, AVF, V5, and V6. And remember, some of these may be more downward because V1 is the right ventricle here, and the impulse SA node, AV node goes, and your net Einthoven's triangles, remember that from last year? Your net electrical activity of the heart goes this way, towards your mid-axillary line there. So that's sort of the direction it's going. So there may be some ventricular leads that get more of a downward deflection as the current is moving away from it. Okay? So that's sort of what we mean by that. The ST segment, one more time. So this segment, if it is depressed, would suggest something called ischemia. So it's one of our ways to figure out if somebody is having what we refer to as ischemia. And as the theme of the week will be coronary ischemia or coronary artery disease, the disease is very complicated. There's all sorts of things in there. There's sort of unstable angina, there's angina, there's blockage, there's not blockage. So ST segment suggests ischemia, not infarction, ischemia. Left ventricular hypertrophy with strain pattern. When you have severe hypertrophy, you could have this segment diminished, or some medication effect can sometimes cause ST segment depression, like with this medication known as digitalis. Elevation is seen in injury. So elevation is seen in injury, and that injury we're referring to is a myocardial infarction, hence the term ST elevation MI and non-ST elevation MI. So these are going to be some terms you'll get more and more comfortable with as the week goes along. I wanted to have this discussion today and not wait a week later, just so that this is in the background, so that even when arrhythmias come in next week, you at least have an idea of what some of the lecturers are talking about. T wave represents ventricular repolarization. It's upright in 1, 2, V3 to V6, obviously where the current is going, and down in AVR, obviously, because it's on the right side and most of the current goes left, and other leads are sort of variable. All right, we're going to practice a little bit, and just for the few of you who are here, feel free. I'll give you guys about 10 seconds or so. Let's start with the rate. What's the rate here? So if we use the theory of going with our QRS complexes and we're looking between there and there and there and there, and this is the large box, how many large boxes between here and here? What's the consensus? About 4, right? So what would the rate be here? 75. So and then if I asked you, that's the rate is 75, what would you say the rhythm is? So is there a P wave before every QRS? Yes. So you would say it's a sinus rhythm and the rate of 75. Excellent. Very good. Okay. Tell me here what the rate is. Yeah, so at least 300 by 6 or 300 by 7, and you're kind of you're ballparking it there, right? So what would you describe this rate as being? This is bradycardia. But is it sinus bradycardia? So is there a P before every QRS? Yeah, there's a P before every QRS. And as far as we know, it's 1, 2, 3, 4, 5. Right at that boundary of what the PR interval should be. I remember I told you between 3 and 5 itsy-bitsy boxes. So from beginning of P here, 1, 2, 3, 4, 5. Yep, so it's normal PR interval. There's a P before every QRS. Therefore, ergo, this is sinus rhythm, but the rate is not normal. The rate is bradycardia. So if this was posted up on one of your UWorlds or steps, and you would say, describe this rhythm, you would say this is a sinus bradycardia. All right, what's this? So again, we would start, again, the rules. Rate first, then rhythm. Rate always number one. What's the rate? Let's see. We'll try to figure out here. What do you guys get? About how many big boxes between the R's? Yeah, between 2 and 3, right? So it's either between what and what then? Yeah, it's between 100 and 150. So what would you say the rate here is? What word would you give this? This is tachycardia. Now, what kind of tachycardia is it? Is it sinus tachycardia? So is it P before every QRS? Yes. And it seems like we got 1, 2, 3. Yeah, and it seems like the interval's pretty stable over there and fixed. So this is referred to as sinus tachycardia. Okay, so the answer here is sinus tachycardia. So you've seen so you guys have now become experts in rate, and you're now experts in rhythm. Give yourselves a hand. Come on, you guys. Awesome. Very good. Very, very good. All right, now we shift gears a little bit. So I've achieved 2 of my primary objectives. We still got a couple more objectives to achieve in the next 20 or so minutes, or 25, whatever. There is, by general classification schemes, there are things we talk about, and most textbooks will say, okay, there'll be the rate part, and then when you go into rhythms, a lot of textbooks will break down bradycardias and tachycardias into different sort of chapters. And then under bradycardias, traditionally, it's like if it was a book of contents, it would say bradycardia, then bradycardia would be divided into first-degree block, second-degree block, third-degree block, whether or not they may be bradycardia or not, so just confusion-wise. And then tachycardias are usually divided into, based on anatomy, and do remember that embryologically speaking, the AV node is part of the atrium. So any rhythm that originates from the AV node and above is referred to as a supraventricular. Any rhythm that are below the AV node is referred to as ventricular. So therefore, if you're in tachycardias, the scheme usually is to break them down into supraventricular tachycardias and ventricular tachycardias. There's another scheme I will talk to you about maybe next week at our review session, where they have something called a narrow complex tachycardia and a wide complex tachycardia. So if you just remember these algorithms, you should be good. So for under bradycardia is the blocks, under tachycardia is sort of these SVT, VT, or narrow complex tachycardia, wide complex tachycardia. Excellent. Now, we've now moved from the normal state. We've moved from Illinois, and now we're moving to the bradycardia state. It's kind of a little bit slow. So that's, we'll go down in there, and let's see what we find. If you notice there's a P before every QRS, P before every QRS, P before every QRS. The only problem seems to be that every PR interval is 0.26 seconds. I had just told you that a normal PR interval is 3 to 5 itsy-bitsy boxes. This is not 5. This is at least 6 or 6.5 or 7. When you have a widened PR interval, but there's always a P wave before a QRS, that is referred to as first-degree AV block. This is first-degree atrioventricular block. So a very slight, delay in the AV node. Not traditionally pathological, just something you would watch, nothing you would do something about. Keep an eye on it. Okay, hey, the PR interval looks cool here. Normal. And then it started getting longer and longer, and boom, what happened here? What happened? You dropped a QRS. So the PR interval kept getting longer and longer and longer, to the point that then you missed that refractory period and whatever, and then the QRS didn't fire, and then you go back to a regular P wave. What is this referred to? This is a second-degree block. However, there's 2 types of blocks in second degree. This is the first type. So this is second degree type 1. or Mobitz type 1 or whatever, but I'll just keep it simple. Second degree block means that you drop a QRS. It's how you drop the QRS that we define the second degree block. In type 1, it's because the PR interval keeps getting longer, 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 and nothing. And then you don't have anything. That's where that arrow was supposed to be, is where the QRS is supposed to be. And then you go back to normal, and then you'll do that. These people also should be observed. I am not so sure what the current guidelines suggest we do with these. We don't put pacemakers in them, but I think there is, cardiologists will say we'll keep an eye on these guys too. These guys you definitely do something about. Okay, you have a normal PR interval. So intermittently, you're like, hey, everything was okay. PQRST, 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 P, boom, it just dropped. Normal PR interval. Just you're intermittently, your P wave doesn't get conducted. So this is your Mobitz type 2, Wenckebach, or whatever other names you've heard about. So this is your second degree AV block type 2. That's all I want you to know. So first degree, just a delay in the PR, it's fixed. You don't drop a QRS. In the second degree blocks, you drop a QRS. It's just how you drop it that defines what type you are. In type 1, you keep prolonging the PR, and then you drop one. In type 2, you have a normal PR interval, and you just drop the QRS. Okay? Excellent. Then, unfortunately, comes a time where if I march these P waves out, they have their own rate. It's like the Ps are marching to their own beat. They have their own intrinsic rhythm, and the QRS has its own intrinsic rhythm. In fact, the P waves have their own rhythm of about 1, 2, 3, 4, 5, so maybe 60, and the ventricle is beating at 1, 2, 3, 4, 5, 6, 7, so whatever, 300 by 7 or 8, like in your 30s. There does not seem to be any rhyme or reason. The QRS is not related to the P is not related to the QRS. This is referred to as total atrioventricular dissociation, and this, my friends, is what's referred to as a third degree block. So we did rate, we did rhythm, we divided it into, there's bradycardias. Under bradycardias, we have first degree, second degree, drop a QRS by prolonging or drop a QRS just intermittently, and then you have this obviously is horrible. This is bad. This is, All right, just a few things to show you about. What do you notice about the QRS interval here? Could you tell me what the rate is here? What's so difficult about saying a rate in this particular rhythm strip? So all this is, guys, is they took one of the leads of those 12 that I showed you where they were placed, and the nurses kind of say, okay, we're just watching this lead now, and that's what these rhythm strips come from. If you notice, it's hard to get a regular rate here, because here you might say it's about 2.5 boxes, 3. Here it's 1.5 box. Here it's 2. So the rate is irregular. The rate is irregular. Can you make up a decent P wave here at all? No. So the rhythm is irregular. There's a classic description that this applies to, atrial fibrillation. So this is what that irregular rate, irregular rhythm. This one, on the other hand, the rate's still irregular, but there's some regularity to this so-called sawtooth pattern that you see here. 1, 2, 3, 4, 5, 1, 2, 3, 1, 2. So this is sort of referred to as atrial flutter. Pathologically speaking, pathophysiologically speaking, probably the same disease processes are going on underlying a lot of these. AFib is a huge thing that we need to know about. Probably in the elderly, biggest arrhythmia that we deal with in the United States. So you'll deal with this next week in one of your cases. So again, so everybody clear with this? Just wanted to show you, not because you're rhythm experts, but just if you saw something like this and you're like, hey, the rate seems to be irregular and it's irregular, it's AFib. So at least you've looked at it. This, on the other hand, suggests that it's a ventricular rhythm. It's like a QRS rhythm. Now, remember I told you that if it was just your ventricles beating on their own, it would be 30, 35, right? Does this look like it's beating at 30 or 35? You seem to be having a complex almost every other large and a half box. So it's about 150 to 200 or whatever that number is. What happens is in that diseased ventricular tissue, they develop something we refer to as a re-entry circuit. And that re-entry circuit keeps going round and round and round. So when that ventricular rhythm becomes a tachycardia like this is what we refer to as ventricular tachycardia. This is VT, ventricular tachycardia. And this is ventricular fibrillation. Sort of just all sorts of schmutz here. Like, all right? So I wanted to just show you those four biggie ones, like AFib, flutter, VTAC, VFib. Now, so objective 1 was rate, objective 2 was rhythm. We've done our blocks and sort of tachycardia, just brief introduction. And the other reason we do an electrocardiogram is to look at what's going on in terms of the ventricular side. This is lead 1. So just a very quick review again, and I know some of you know this, but we have the limb leads, right? So 1 goes from here to here, 2 goes from here to here. So obviously 2 would get some of the inferior part and some of your right side. 1 would get the top of your heart, and 3 would go this way, which means it would get your inferior portion of the heart or maybe even the left side of your heart, right? With the ventricular side, we developed 6 leads, and that gave us 6 pieces of information. The limb leads, we only have 3, and you're like, wait a minute, you told us there's 12. So what they decided to do is take a couple of these leads and get more information out of them. So there's something we call AVR, R meaning right, AVL, L meaning left, and AVF, F meaning floor. So that's how I remember it. So you have your regular limb leads, and then you have 3 augmented limb leads to give you more information about the right side of the heart, AVR, left side of the heart, AVL, and the floor of the heart, or the inferior portion of the heart, AVF. So if there's an ST elevation and 2, 3, and AVF, it's the inferior wall MI. Boom, got it. If there is an ST elevation in lead 1, AVL, and V6, you're like, this is a lateral, it's probably LAD, circumflex. You're like, if I'm going into the cath lab today, I'm going to be putting a stent into the circumflex. This is sort of the questions that you guys, that's how I would ask it if I was on the steps. I would say, this is how I would test your anatomy. I'd be like, okay, here's an MI, it happened like this is what's going on. Tell me where you want to put the stent in. Or, what do you think is going on? Or which is the artery that's involved? That kind of stuff. So the bundle branch block here is, so these 1, 2, 3, these are your limb leads. AVL, AVR, AVF, these are again your limb leads. And this is V1, V2, V3, more on the right side, V4, V5, V6, more on the left side. What does this look like to you? Honestly, just if you just walked into the room, you had no medical school, and you just walked in and you say, what does this look like to you? What did he say? You said something. Mountains or, very narrow mountains though, like Twin Peaks kind of thing. So what if you're in grade school and you watch this? What do you think they would think of? Huh? The letter M? Oh man, you guys, these don't look like bunny ears to you guys? So if you see bunny ears, on the right-sided leads, that's a right bundle branch block. If you see it on the left sides of the leads, that's the easiest way to know a bundle branch block, is you see an R, S, and then you something called an R prime. You actually have these sort of bunny ears. So if you were to walk in, I'm hoping it, like if a kid would have walked in, they would have said, Bugs Bunny. I guess, is Bugs Bunny too old now? Does anybody, I thought those things were, you would watch, they would stand the test of time, Warner Brothers, and anyway. So this would be the bunny ears, and or something like this, like you have an R, S, R prime. And if you see that picture, and obviously, doesn't it make sense? Your QRS segment is increased. So obviously, there's a block there in the bundle. Remember, it's going to go through there. That's suggesting ventricular depolarization. So there's a delay and ventricular depolarization. So it makes sense that a widened QRS is a bundle branch block. It would make sense. And so it's more than 3 itsy bitsy boxes. If it's wider than that, it's a bundle branch block, or a few, or just 1 or 2 other things. So, and if it's on the right-sided leads, it's a right bundle branch block. If it's on the left-sided leads, it's a left bundle branch block. Hypertrophy, very easily. So I was trying to tell you guys about the principle of hypertrophy. Hypertrophy means that the bigger the thickness of the muscle, the higher the upward deflection will be. So if you look at this, that's 5 millimeters, 10 millimeters, 15 millimeters, 20 millimeters, almost 23 here. And usually we take the S in 1 and we add it to the R in 5 and 6. And if they're greater than 35 millimeters, it's left ventricular hypertrophy. There's a lot of criteria. There's also, remember, AVL, VL, left-sided, left ventricle, left-sided. If it's greater than 11 millimeters, that's also another criteria for left ventricular hypertrophy. Well, I won't ask you specific criteria. I think that's more, you'll be more responsible for those next year. But this, you should at least recognize that this is hypertrophy. All right, and then the last objective. This was that normal ST segment I told you guys about right here, okay? You see that? So if I went to this EKG, there's a P, QRS. Look at this ST segment. What is this? It's like that tombstone pattern. Now, not all MIs present like this, but there's a variation in the ST segment elevation that we have. So that's just so that you know. But we showed you this so you can know what an ST segment infection elevation is. How do you localize it? So based on where I told you the leads are. So if I had an ST elevation in 1, this way, AVL, left side, V5 and V6, more on the lateral left side, that would be a lateral MI. 2, so 2, 3, AVF, sort of leading to that inferior portion of my heart, inferior wall MI. V1, V2, probably a septal infarct. V2 to V4, probably an anterior wall MI, LAD, probably that's your, yeah. Again, could be some minor variation amongst this, but this is where you would start thinking. And then I would add to this, in your own mind, you would say, lateral, what am I thinking? What's laterally supplied there? What would I do? Inferior, right coronary, septal, is that circumflex or still LAD? And then you have the marginals that come off some of those arteries. So my whole idea today, if we went back to the objectives here, and I'm hopefully, I wanted to make sure that you know why you do an EKG is about the electrical activity of that. So both, even if you have a mechanical damage, plumbing side, it can give you information like ST segment elevation or depression, LVH, all of those things can be told by this. And also electrical activity, bradycardias, tachycardias, blocks, arrhythmias. Describe the waves. We talked about the P, QRST, and the intervals. And we also talked about what happens when they're prolonged. We recognize bradycardia and tachycardia, okay? We relate the location of the lead to the anatomy of the heart. And we also recognize AV blocks. And we identify and localize coronary ischemia and infarction. So just based on whatever I've been saying over the last 40, 45 minutes or so, you should be able now to be able to answer these 7 objectives, hopefully, okay? So just from what we've said, everybody clear with this concept? Okay, again, it's just getting you into the door now. And now, as we go through this week and next week, and then as we meet towards the tail end of next week in our review session, if something does not clear up, you're like, oh, I went through this case, and I wasn't very clear about that rhythm. Can we go over it again? We can talk about that again. And there'll be a few, and luckily you guys have some very excellent facilitators with PAPHS, and they'll always chime in with a few pearls along the way that you can add to what I just said. So think of what I did as more of the beginning side, and then you're going to add to this. But I think most of what they want you to know for step 1 in particular, this is key. This is, if you know this, I think you're home free. I'm sure there was a panel here before when I came in earlier. I think that's sort of what they were talking about, if I'm not mistaken, about preparation and these sorts of things. And I think that would be a good resource to kind of latch on to. So therefore, if the theme for the week is coronary artery disease, and coronary artery disease, one of its manifestations is somebody could have a heart attack or a myocardial infarction, and you're like, how would I diagnose an MI? And there's only three ways. There's the history and physical exam, the classic story, and then I know sometimes it's not classic. There's the electrocardiogram, so maybe the ST elevation, not ST elevation. And then there's the third piece, and that's what 11 o'clock is about. The third piece is the cardiac enzyme, so the laboratory data. So there's the history and physical, there's the electrocardiogram, and then there's the enzyme. Those are the big three things that everybody does. Chest pain, boom. You're in the ER, chest pain. EKG, get a good history from the guy. Oh, okay, when did it start? Was it 30 minutes ago? Is it stable? Oh, it just happens when I mow the lawn, but otherwise it's okay. Is that acute? Is that, is that angina or is that unstable? So you're kind of moving, that's where your history and exam comes in. And then your EKG is like, well, let's do the EKG. What do we see? Well, we saw ST elevation. We didn't see ST elevation, but we saw a few other things. We saw ST depression. Oh, that's ischemia. So we're still in that disease. We're still in the big category of coronary disease. We just have to decide where do we put this. ST elevation, non-ST elevation, stable angina, unstable angina. So think that way, and then you'll say, okay, where are the labs? So this is sort of where those cardiac enzymes come in. And as Dr. DeCruz will tell you, in this day and age in 2017, there's just a few markers that we have that are your gold standard. He'll probably go through the history of the markers because there's some hospitals still, like maybe you may not have the most updated assay available, so you're like, hey, how would I check it and what else would I do? So that's what we have. So any questions so far? And then hopefully I'll get a chance to huddle with you guys Friday. Yeah, most of that format, it says last week it's predominantly pathology and pharm. So for your PAPHS sessions, we usually reserve all of the questions from those for the summative exams. So well, I'm sure they'll help out with some of the tying in the pathology concepts. I had a family emergency last week, and that's why I wasn't able to be here. My plan was to be here on Friday with Dr. Broderick to give my clinical side of how I use some of those drugs, but I'll still do that. I'll find a time, if not later this week, next week, and I'll give you a little bit of a snippet of how I, as a doctor in internal medicine, end up using blood pressure medications and how am I thinking. He actually went through a lot of those guidelines. There was a chart from JNC8 and things. So if you ever get a chance, those are really useful documents to kind of just for next year. All right, guys, thanks. And I think Dr. DeCruz should be on his way. I'll just double check here. All right, yeah, you can take it off.
All right.
Good. This is awesome. Blackboard, just pull it up from there.